Welcome back to Diabetic Files. Hope everybody had a great Valentine's Day weekend. So, we're going to talk about phantom limb pain. I went through an episode like this before, but it was very scratch the surface. But I would like to go a little bit more in depth in this. So, okay, we need to picture this. Your patient leg is gone, unfortunately. Amputation is completed, incisions heal, prosthetic fitting schedule, and they look you dead in the eye and say, Doctor, my toes are on fire. And you say, Oh, your toes are not because they're not physically there. I also had a patient that was almost a TMA, but they were saying that they still feel like their toes are there and they still hurt. And I was like, Oh, you have phantom limb pain. And she was like, yeah, they were saying that there's nothing they could do, but there actually are quite a few treatments. So let's go more in depth into phantom limb pain. It's actually one of the most fascinating, yet frustrating, yet very neuropathic pain syndromes in medicine. So today we're going to cover how phantom limb pain was discovered. The mechanism is actually a very complex mechanism. It includes the peripheral nerves, the spinal cord, and there's something called the prediction machine theory. Interesting. And why diabetics get hit hard with this after amputation, how to diagnose it, what to rule out. Remember, this is for medical education. Like I said, let's make common sense common. What the latest research says about it, from mirror therapy to nerve surgery to neuromodulation, and a clinical approach of how you can actually use it in limb salvage, right? And post amputation care. So, who discovered phantom limb pain? So, phantom limb experiences have been described for centuries, but two names matter most. So, Ambrosia Paré, like Tare, okay, in the 1500s, a French military surgeon, one of the earliest to document phantom sensation or pain in amputees after the battlefield injuries. Modern reviews cite that Paris Ambroise Paré observed among first clinical descriptions. Then there's somebody called Silas Ware Michel in the 1800s, an American physician, and forgive me if I pronounce it wrong, an American physician who coined the term phantom limb and popularized the phenomenon clinically in the 19th century, especially after the Civil War when many soldiers underwent amputations. So phantom limb pain isn't new, but what is new is they're finally admitting that it's not imaginary, okay? It's actually neurobiology. So, phantom limb pain versus residual limb pain versus the other stuff. So, this part, like, it's about mislabeling because mislabeling the pain will cause mistreatment. Okay. So, phantom limb pain, PLP, is pain perceived in the missing limb. So, whether it's toes, foot, ankle, calf, okay, even though it's amputated. Residual limb pain, RLP, it was formerly described as stump pain. This pain is pain in the remaining limb tissue, so like along the incision, the skin, the muscle, bone, often linked to the wound healing problems, prosthetic fit, infection, ischemia, neuroma, etc. And then there is phantom limb sensation, PLS. So, not always painful, but patients may feel the limb is still there, positions, moving, itching, or stuck. But phantom limb sensation is a subset. And if I'm wrong, I apologize. So, the mechanism. So, why does phantom limb pain happen? So, phantom limb pain is best understood as a multi level. So, the peripheral nerve to the spinal cord, and then the brain circuits, and then the cognitive slash emotional processing. So, modern reviews emphasize that it is not just a one cause thing, it's a system level phenomenon. So, peripheral mechanism, the nerve endings are not quiet. So, after amputation, severed nerves can form neuromas. They can generate ectopic discharges, which causes abnormal spontaneous firing, and they can become hypersensitive due to inflammation or mechanical irritation. So even though the limb is gone, the nerve highway still exists and it can keep sending danger signals upward. So, in clinical translation of this, if the residual limb has a focal, what we say, electric shock pain, tapping the areas triggers the pain, like kind of like a tunnel, like triggering pain, or the pain worsens with a prosthetic pressure. Think neuroma or residual limb pain, but neuroma activity can feed phantom limb pain. Then next is the spinal cord mechanism. So the amplifier is stuck on high. So loss of the normal input from the limb, which we call deafferentation, can drive a dorsal horn hyperexcitability, can reduce inhibitory signaling and central sensitization. So when we say central sensitization, that's the volume knob turn, so now the non-danger signals can be interpreted as pain. Then the brain mechanism. So the brain mechanism includes like the cortical maps, mismatch, and prediction errors. So there are two big, often overlapping framework when it comes to the literature of the brain mechanisms when it comes to phantom limb pain. So first, the maladaptive neuroplasticity and the cortical reorganization. So after amputation, the brain's somatosensory and motor maps can change. And some models propose that invading neighboring representation and altered sensor motor networks contribute to phantom limb pain. Then also there's a mismatch, what they call body matrix, neural matrix idea. So the brain constantly predicts what the body should feel like. And when the motor intention like gets no confirming sensory feedback, the brain experiences a mismatch, sometimes interpreted as pain. And this, oh, forgive me, I'm a little stuffed up. This type of prediction error framework is discussed across modern reviews of phantom limb pain. So it's like your brain is like, I sent the command, why didn't the foot move? Because the foot isn't there. Okay. And sometimes the brain will interpret it as there must be danger. So it outputs it as pain. Next is the emotional learning network. So why anxiety, trauma, and depression matters. That's why it actually does matter, especially with patients who have amputations. Okay, so phantom limb pain isn't just psychological, but mood and trauma circuits can increase the pain, can disrupt the patient's sleep, can worsen the pain modulation, and can reinforce avoidance and catastrophizing. So the best evidence supported care models are multidisciplinary, not just medication only. So you have to refer them to a psychologist, psychiatrist. So, where does phantom limb pain happen? Like common patterns and symptoms. So, common locations for patients who experience phantom limb pain. And apparently, it really is a big deal in the amputee community because it isn't a lot of people still experiencing the pain, and there isn't a one fits all medication or treatment plan for it. I see a lot of patients complain about it after amputation and they just don't know what to do. So patients often report pain in the distal parts like the toes, the forefoot, the arch, the heel, even below the knee or even above the knee amputation. But reviews describe phantom limb pain as a frequently distal, more and vividly localized. So common qualities are like the way the patient would describe phantom limb pain is as burning, on fire, stabbing, knife-like pain, electric shocks, cramping, squeezing, feel like the toes are curling, the toes are twisting, nails digging in, itching that hurts, and a cold pain like frostbite-like pain. So what are some of the triggers for phantom limb pain? Stress, fatigue, poor sleep, residual limb irritation or prosthesis problems. Weather changes are very common that patients report. Infection, illness, high glucose variability, that's very important when it comes to our diabetics. And then timeline. Phantom limb pain can begin immediately after surgery or weeks later or even just become chronic. But large review reports that phantom limb pain is common overall, like quoted common within like 50 to 80% in patients, okay? The 2024 meta-analysis discussed a worldwide prevalence around the mid-60s range for phantom limb pain in amputees. So why does diabetes can phantom limb pain happen after the amputation? So diabetes adds a multiple amplifier to phantom limb pain system. So we have to remember diabetics, most of them have pre-existing peripheral neuropathy, diabetic peripheral neuropathy. So if the nerves are already damaged and already hyperexcitable, the nervous system is primed for the neuropathic pain post amputation. Next is the ischemia and inflammatory burden that happens with diabetes. So many diabetics amputations are driven by peripheral arterial disease, aka PAD, ischemia, or infection. So that pre-amputated pain and tissue injury can train the system toward a chronic pain pattern, what we call like central sensitization. Okay. Next is higher infection risk and delayed healing that happens often in diabetes. Residual limb problems can feed ongoing nociception and worsening both the residual limb pain and the phantom pain loops. And then the glycemic variability. So glucose swings can worsen neuropathic pain. That's what I tell a lot of my patients perception and also affects the sleep quality. So indirectly, phantom limb pain severity, could be, I would say, affected by the glycemic variability. So clinically very common, even if it's hard to quantify perfectly in a patient. So the important nuance is some data suggests that phantom limb pain prevalence may be high in both diabetics and non-diabetic amputees. One study found no significant difference in the prevalence between the groups, but diabetes may have more neuropathic burden overall because the neuropathy, the vascular disease, and the wound complexity stacked together. So, in diabetics, it's not just phantom limb pain, it's phantom pain on top of the nervous system that has already been living with neuropathy in the neighborhood. So, how do we evaluate phantom limb pain like a pro? So, phantom limb pain is a clinical diagnosis, but the skill of distinguishing it is, hard. And that's why you should refer the patient to a neurologist. Okay. So, ask these questions. What exactly is the pain? Where exactly is the pain? So, is it where the missing toes are on the foot? Then it's most likely phantom limb pain. Is it along the incision site or the stump site? Then might be residual limb pain or surgical complication. So, what does it feel like? Neuropathic descriptors are burning, electric, are quite common in phantom limb pain. And then when did it start? I mean, it varies when it starts. It could be immediate, like we said, after surgery, or delayed or worsening with time. And then what triggers it, like we said, it could be the prosthetic fit, irritation, touch, stress, nighttime. And then any red flags would be fever, drainage, progressive swelling, new discoloration, severe focal tenderness. So one other thing is you should never confuse phantom limb pain with residual limb infection or osteomyelitis. That's why I don't like people, because pain is subjective, right? People usually be like, "Oh, it's nothing," but it is something. They feel it. They feel it. You're not feeling for them. They're feeling it. So you have to take it into account and take it seriously. So also, do not confuse phantom limb pain for ischemia of a remaining limb issue, or do not confuse phantom limb pain with a DVT, especially if there's swelling or pain. Do not confuse phantom limb pain with a neuroma. Neuromotor has a positive to now sign most of the time. And then do not confuse phantom limb pain with complex regional pain syndrome. This is less common in post amputation patients, but it is feasible. And then do not confuse phantom limb pain with a prosthetic socket fit, or pressure injury pain. Okay. So you have to remember to always inspect the wound incision site, palpate for a focal neuroma tenderness, the Tenel sign at the nerve end region, check the skin temperature if there's asymmetry, skin temperature asymmetry, swelling erythema, vascular evaluation of the remaining limb, make sure that happens, and then functional assessment and prosthetic interface assessment. So, the modern consensus of the phantom limb pain is that it's multimodal. So it plus individualized care gives the best income. So it's not like a one size fit all. It has to be individualized plus a multidisciplinary approach as well. So education and rehab is a good foundation for patients. So normalize without minimizing the patient's pain. This is known as neural pain condition. It is treatable. It may take quite a few different combinations. Optimize the limb environment for the patient, make sure that there is a good socket fit, skin protection, and desensitization. Treat residual pain drivers aggressively, like if there is an infection or a neuroma or if there's pressure along the area. And then also emphasize sleep, okay? Because pain modulation is a whole body system, okay? Now, different type of therapy. I'm sure a lot of people have heard of mirror therapy when it comes to phantom limb pain. So it is widely used and it is low risk, but studies vary in protocols and outcomes for mirror therapy. So in 2025, scoping reviews highlights a major discrepancy in how mirror therapy is delivered and notes that effectiveness of mirror therapy does vary, suggesting that protocol details do matter. So clinical pearls when it comes to mirror therapy often works best when it's done consistently, like on a daily basis in short sessions, integrated with movement intention and combined with education and desensitization. Next is graded motor imagery, GMI. So typically progress from laterality, recognition, motor imagery, and mirror therapy. So some motor approaches are actually getting tongue tied, actually exploring VR, enhanced visual feedback as an extension of sensory motoring retraining. Okay, so that's pretty cool. And medication. Medication, a lot of patients I hear that they get on gabapentin or Lyrica or amitriptyline or SNRIs, things like that. But leave that to the neurologist, okay? The people who are specialized in that, okay? In some selected cases, they do use tramadol or topical agents for residual limb pain components. Compound creams work very well, in my opinion, but also be cautious for long-term opioids, okay? That's why also they could be referred to pain management, but I would refer to neurologists to figure out to make sure it's phantom limb pain, make sure it's not residual, things like that, okay? And then, so what are some of the other latest interventions or neuromodulations for phantom limb pain? So, non-invasive brain stimulation. So, a 2025 systemic review or meta-analysis of neuromodulation techniques report beneficial effects across certain neuromodulation approach. Then spinal cord stimulation. So there was a 2025 scope review suggesting that spinal cord stimulation can provide meaningful reductions in some phantom limb patients, but outcomes vary and long term data are limited. Next is dorsal root ganglion stimulation. So, DRG. Stimulation is attractive because it can target specific dermatomes, and broader neuropathic pain reviews discuss its promise for focal refractory pain syndromes like phantom limb pain. So, what about surgeries that target the nerve end problem? So, there are this is like where limb surgeons, plastics, pain specialists can get excited. So there is targeted muscle reinnervation. So TMR reroutes severed nerves into motor branches, aiming to reduce neuroma formation and reduce the pain and improve signal pathways. And there is ongoing research into prophylactic targeted muscle reinnervation at the time of amputation for prevention of that. That's really cool. Rein Regeneration of peripheral nerve interface. So, regeneration of peripheral nerve interface uses muscle graft interface for nerve endings, aiming to reduce neuroma pain and potentially improve prosthetic control. So, note that phantom limb pain may be harder to treat when there is a chronic central sensitization that is already established. Next, I'm saying the word cure. Okay. So, literature does not promise a single cure, like I said, for phantom limb pain, but it is hopeful and the direction is getting to a good one. So, like we said, the targeted muscle regeneration, renerve, re-nerve innervation. Okay, forgive me. So, when it comes to practical application of phantom limb pain, when you have to discuss it with a patient, when a patient says, my missing toes hurt, rule out first emergencies like rule out infection, ischemia, wound breakdown, DVT, prosthetic pressure injury. Make sure. Then you have to classify, is it phantom limb pain or is it residual limb pain? Okay. Or is it mixed? Next is tier one. So education, limb optimization, sleep and mood support. You definitely should refer the patient to neurology and pain management. Also psychiatry or psychologist for mirror therapy, okay? And then neuropathic pain regimens. As a person, I do avoid opioids because of the high addiction rates, so I try to avoid that, and I just leave it to the pain specialist. But if it persists, yes, pain specialist intervention referral, okay? Evaluate for neuroma, so consider imaging if it's focal, discuss neuromodulation options or advanced rehab. Now, next is symptom checklist. So, like I said, pain felt in the missing limbs, either it's toes, foot, hand or fingers, okay? Burning, stabbing, electrical shocks, cramping. If it's episodic or if it's constant, if it's worse at night, if it's triggered by stress, fatigue, or a prosthetic irritation. If you haven't noticed, mentioned prosthetic irritation multiple times, so definitely rule that out. And like we said, red flags, make sure rule out ischemia, infection. If there's fever, drainage, foul odor, if there is escalating stump redness or swelling, if there is a new severe focal stump pain, if there is a change in color, if there's a coldness in the remaining limb tissue. I won't go that much into questions for that, but hopefully this episode was helpful. So, phantom limb pain is not fake pain, it's actually a real pain pathway that survived the surgery because the nerves, the spinal cord circuits, the brain mass don't automatically update just because the limb is gone. And for your diabetic patients, you already have a nervous system that is under stress from the neuropathy and ischemia. So that's why we have to treat phantom limb pain like it's a whole system problem because it is. And this is the Diabetic Foot Files. I'm Dr. G, and I hope everybody has a great Tuesday. Take care of your feet because they take care of you.